Hello friends, welcome to Healthwizac Medical Concepts Simplified. In this video, we will learn about HHS, that is hyperglycemic hyperosmolar state. HHS, as the name suggests, is a clinical condition diagnosed with the presence of high sugars and high osmolality and is one of the life-threatening complications of type 2 diabetes. The core issue responsible for HHS is insulin deficiency in diabetics along with inadequate fluid intake. In normal healthy subjects, primary energy source is derived from glucose, whose regulation and control, that is glucose equilibrium, is maintained by brain, liver, skeletal muscle, pancreas and gastrointestinal peptides. Pancreas produces two important hormones, namely glucagon from alpha cells and insulin from beta cells, which play an important role in glucose regulation and uptake. Insulin facilitates entry of glucose in cells and makes it available for use. In diabetic patients, due to insulin deficiency and reduced insulin sensitivity at cellular level, glucose available in the blood cannot enter the cells and is not available for use. In this condition, cells starts deriving energy from other sources like fats and glycogen stored in the liver through process called gluconeogenesis and glycogenolysis. This excess glucose in blood causes hyperglycemic state and also increases the osmolality level. This hyperosmolar state causes shift of fluid from ICF to ECF, causing osmotic diuresis and ultimately tissue-level dehydration, which is more aggravated by inadequate fluid intake and thus giving rise to HHS. HHS usually presents with a relatively long-standing history in contrary to DKA, which has an acute onset, and hence sugar levels are found much higher and dehydration is more profound in HHS. Due to relatively less insulin deficiency and chronicity of the illness, ketone bodies are usually absent in HHS, which differentiate it from DKA and also stands one of the key factors in its diagnosis. In presence of inadequate sugar controls, HHS is usually triggered by other illnesses like sepsis, pneumonia, stroke, myocardial infarction, and etc. Symptoms presented in HHS includes polyuria, polydipsia, reduced appetite, weight loss, lethargy, mental confusion, giving rise to clinical findings of hypotension, tachycardia, and altered mental status. Now, let's have a look at the diagnostic tools used in the HHS. Along with the symptoms and history, diagnosis can be primarily made through sugar levels, ABG, and ketone levels in blood and urine. The first and foremost finding may be hyperglycemia, which is present in the range of 600 to 1200 mg per deciliter. Due to this hyperglycemic state, osmolality increases and may be detected in the range of 330 to 380 milliosmol. Hyperosmolar state causes shift of fluid from ICF to ECF, causing dilutional effects, and thus initial pseudo-hyponatremia may be present. During this shifting of fluid, potassium also gets shifted to ECF, causing initial hyperkalemia followed by hypokalemia once insulin is started. Along with this, hypomagnesemia and hypophosphatemia may also be evident. Excess glucose is secreted through kidneys, causing deranged creatinine levels. Also, urine may show glycosuria with elevated specific gravity along with traces or absence of ketones. Serum beta-hydroxybutyrate level, which is a specific marker for ketosis, may be normal. ABG may show pH of more than 7.3, bicarbonate of more than 18, and normal to slightly raised anion gap. Apart from this, infection may show leukocytosis, which may be the predominant cause of HHS. Now, let's have a look at the treatment part of HHS, which comprises of correcting dehydration through IV fluids, normalizing sugars through insulin, correcting electrolyte abnormalities, and treating the primary cause. As soon as the diagnosis of HHS is confirmed, first step, that is rehydration with IV fluid, should be started at the earliest. Due to the long-standing history of HHS, dehydration is more pronounced and total fluid deficit may be up to 9 to 10 liters. Patients should be commenced with IV fluids, preferably 0.9% normal saline at the rate of 20 ml per kg body weight with initial bolus of 1 to 3 liters in first 2 to 3 hours, along with oral hydration if not contraindicated. After initial stabilization, rapid correction should be avoided as rapid reversal in hyperosmolar state may cause neurological symptoms. If sodium level is more than 150, IV fluid should be shifted to half strength NS, that is 0.45% normal saline, and should be gradually shifted to dextrose containing fluid, that is D5%, to correct the free water deficit. Total correction should be gradually carried out over 1 to 2 days with hypotonic fluids at the rate of 200 to 300 ml per hour. Next step is to normalize sugar through insulin. Hyperglycemia should be treated with insulin infusion at the rate of 0.1 unit per kg per hour, followed by combination of long and short-acting insulin subcutaneously or intramuscularly later. Sugar correction should be carried out gradually to avoid cerebral edema. Once sugar level falls to 200 to 250 mg per deciliter, instead of stopping insulin infusion, it should be continued at a lower rate of 0.02 units per kg per hour. Third step is to correct electrolyte abnormalities. Initial electrolyte readings may sometimes give false picture due to shift of fluid from ICF to ECF, causing dilutional effects. Hence, electrolyte abnormalities like pseudohyponatremia and pseudohyperkalemia should not be treated urgently, and other valid causes for these should always be checked. After initial rehydration, hypokalemia may be manifested due to shifting of fluids in ICF, and then potassium correction should be started, preferably through IV. Total correction needed may be up to 20 to 80 millimoles. For mild to moderate hypokalemia, in absence of vomiting, oral correction through syrup along with peripheral IV lines can also be considered, whereas for severe hypokalemia, IV routes through centrovenous line are preferred to avoid thrombophlebitis. Total correction needed may be as follows. If potassium is less than 3.3, then 40 to 80 milliequivalents of potassium correction may be needed. If potassium is between 3.3 to 5.2, then 20 to 30 milliequivalents of correction is needed. And if potassium is more than 5.2, then no correction is required. If you want to know more about correction of hypokalemia, please click on the I button on the right top corner of the screen or click the link given in the description box below. Finally, other triggering causes of HHS should be looked for and should be treated aggressively with broad-spectrum antibiotics in case of infections and other treatment modalities in case of other underlying illnesses. Next, let's have a look at the differential diagnosis of HHS. This includes diabetic ketoacidosis, alcoholic ketosis, starvation ketosis, and euglycemic diabetic ketoacidosis. Now, let's have a look at the difference between diabetic ketoacidosis, that is DKA, and hyperglycemic hyperosmolar state, that is HHS. It could be broadly classified under three categories of history and onset, symptoms, and pathological findings. DKA usually presents with acute history and onset, whereas HHS usually present with long-standing history and onset. Symptoms like nausea, vomiting, abdomen pain, Kussmaul's breathing are more prominent in DKA, whereas in HHS, these symptoms are usually less severe. In diabetic ketoacidosis, sugars are usually in the range of 250 to 600 mg per deciliter, whereas in HHS, sugars are in range of 600 to 1200 mg per deciliter. Dehydration or water deficit in DKA is maybe up to 3 to 6 liter, whereas in HHS, dehydration or water deficit may be up to 9 to 10 liters due to the chronicity of illness. Ketosis is more profound in urine and blood in DKA, whereas in HHS, ketosis is usually very minimal or absent. ABG may show more severe acidosis in diabetic ketoacidosis, whereas ABG may show mild to moderate acidosis in hyperglycemic hyperosmolar state. Finally, osmolality in DKA may be up to 300 to 320 milliosmoles, whereas osmolality in HHS may be up to 330 to 380 milliosmoles. Finally, friends, patient education regarding diabetes, proper use of insulin, and its complication is one of the key factors in avoiding complications like HHS. So friends, this brings us to the end of this topic. Hope you find this information valuable and applicable in your clinical practice. Please do like and share this video and hit the bell icon for more latest updates. And for more such informational videos on medical topics, please subscribe to YouTube channel Healthwizac-Medical Concepts Simplified. Thank you.